Real pleasure for me to welcome you to the first in a series of webinars that the IHF is bringing to its members under the theme Strengthening Women Leaders for Women's Health. The IHF Women in Leadership Special Interest Group, in collaboration with ICON Group, will be bringing you 3 webinars in this series before we have an in-person event at the World Hospital Congress in Seoul in October. We hope to see many of you there. Today's outstanding panel will explore the theme Women Leaders Changing Women's Health, Advancing Prevention, Screening and Awareness. And while today we're focusing on women leaders, we do recognize that improving women's health is not a niche issue. Rather, it's a system-wide priority and one that requires commitment from all leaders across healthcare and beyond. But that said, women leaders can bring a particularly valuable perspective to this work, and lived experience, whether direct or indirect, often shapes priorities in meaningful ways. And historical gaps and inequities in women's healthcare may resonate more personally, which strengthens the urgency for change. And importantly, when leadership reflects the populations that it actually serves, the policies and solutions tend to be more inclusive and effective. So to discuss this further, it's my pleasure to introduce our speakers for today. Chair and speaker, Dr. Penny Kecagioğlu, is a healthcare leader with 23 years experience in the UK NHS and is also Chief Medical Officer at ICON Group and Chief Clinical Information Officer and Clinical Oncologist at University Hospital Coventry and Warwickshire in the UK. Wears many other hats as well. He has a very impressive CV if you want to look her up on LinkedIn. We also have joining us today Dr. Preeta Reddy, who is Executive Vice Chairperson of Apollo Hospitals Group India, where she's built a health ecosystem of over 12,000 clinical staff and helped establish new areas of work, such as Asia's first gender intelligent hospital, which we'll be hearing more about today, and the Apollo Research Academy. Professor Nazarine Derekshan is Professor of Experimental Psychopathology and Head of the Growth and Resilience in Trauma Center at the National Center for Integrative Oncology and the founder of BRIC, the Center for Building Resilience in Breast Cancer, based in the UK. So it's a wonderful panel and we look forward to the discussion. If anyone has any questions, please put them in the chat and we'll hopefully have time to come to them at the end of the session. So I'll hand over to Dr. Penny to introduce and frame the session. Dr. Penny.
Thank you so much, Ilona, and thank you to the IHF for the collaboration and to the speakers who are joining us and the participants who have joined us this afternoon. I'm delighted to be chairing this special interest group on women's health. As Ilona mentioned, women's health is really a very important subject. It encompasses physical, mental health, but it's also shaped by the culture, gender inequalities, social determinants of health. And we know from research and from different organizations, including the WHO work, that there are inequalities in working conditions, there are power relations, and there are challenges with access to screening and treatment for women across the globe. That may lead to higher risk factor exposure and worse health outcome for women. For example, we hear and we know there are shortages of women health providers. I know Dr. Reddy will touch upon that. There are restrictions in medical care in some countries, and there are low screening uptake in some countries. And non-communicable diseases, including cardiovascular disease, diabetes, cancer, mental health conditions, are a growing burden. They get often underdiagnosed or undertreated. So as women leaders, it's our really responsibility and duty to improve that and influence health policy. Some women groups that have worse access to treatments are maybe Indigenous women, migrant women, women with disabilities, and older women. They're often underserved. And finally, some research from Ipsos Health Services has shown that actually 51% of women consider mental health a primary health concern versus 40% of men. And that disparity is pretty common in young women. So that is the context of why we are here today, a very, very important subject. And my specialty is cancer oncology. So I would like to give a talk around how do we promote some prevention and healthier lifestyles when it comes to cancer, not just to prevent cancer from happening, but also if people get diagnosed with cancer, it's an opportunity to change behavior and lead a better life to prevent cancer coming back and other conditions. So I will refer to my slides, which I'm going to try and share. I want to talk a bit about breast cancer and key facts, because it's a really very common cancer. And it's common in developed countries, but also common in underdeveloped countries. And in fact, the latter, the mortality is a lot higher than the developed countries. So there are disparities globally. Breast cancer doesn't just happen in women, it happens in about 1% in men as well. And most breast cancer cases are not due to genetic causes. About 30% of breast cancer can be prevented with lifestyle changes alone. Implementation of breast cancer screening has reduced mortality, but there are global disparities existing in accessing those services. So prevention, what do we mean? 4 in 10 cancer cases can actually be prevented. That is a big number. And if we think about the factors that can cause cancer in our bodies, there are many factors. They're environmental, may be out of our control, but there are also factors that we can control, like our diet, like how much we expose ourselves to the sun, whether we drink alcohol or we don't, whether we smoke or use other substances that may cause inflammation in our bodies and predispose us to cancer. So there are things that we can do in our lives, which I will mention later on in my presentation. It's very important to recognize that this is all evidence-based, and the World Cancer Research Fund did publish a really good research report showing the risk factors that actually increase the risk of breast cancer, and also tangible ways of changing those lifestyle habits. So, for example, if we take premenopausal women with breast cancer, there are certain predisposing factors, and there is strong evidence around that. So, for example, by doing physical activity, and at least the recommendation, which is 150 minutes a week, significantly reduces that risk. There is some controversy in that research showing that overweight at young age can actually increase the risk. But if we see the next slide after that, obesity definitely is a risk factor for breast cancer, so we need to tackle it. Breastfeeding reduces the risk of breast cancer significantly, whilst alcohol consumption can increase that risk. There are other factors which have a limited evidence, so I will focus on those which has strong evidence. For postmenopausal breast cancer women, this is very, very similar. Exercise reduces risk significantly. Being obese and overweight in adulthood, you can see, increases the risk significantly. Previous breastfeeding also reduces the risk. And of course, alcohol consumption is a risk throughout women ages. So the impact of obesity is huge. And how can obesity actually trigger breast cancer is through molecular pathways. Obesity and fat, excess fat, can actually cause release of certain proteins, certain factors that can induce chronic inflammation in our bodies. It can also cause excess estrogen production, which is one cause of breast cancer in women. I mentioned diet. There is plenty of evidence now showing that a diet which is high in fiber and low in processed foods or red meat is actually better for health. We call it a Mediterranean diet, but there are also other diets that are based primarily on plant food, which we know they're healthier. And why? This is because a varied diet which is based on plant can actually influence the way our microbiome works, which is our good bacteria in our gut. And they actually counteract those inflammatory pathways I mentioned, which are caused by the high fat in our bodies. So one example is Mediterranean diet, but there are others. And you can see that there is research on it for certain types of cancer, particularly aggressive, such as estrogen negative or HER2 positive breast cancer. fruits and vegetable consumption can actually be a protective factor. I mentioned about the impact of exercise. Again, there has been a recent research in colon cancer that's showing exercise after diagnosis of cancer can actually significantly improve survival over and beyond the treatments that I as an oncologist give. Now, what does this picture show you? So this is tumors in mice. And on the right-hand side, these are the tumors, the mice that have not been exercised, okay? So they are the control. And you can see the black is the amount, the volume of tumor. And on the right-hand side, as you look at the slide, it's tumors in mice that have been exercised. You can see the black component, which is the density and volume of tumor, has significantly reduced only with exercise. So this is, I like to show that slide because it's really, really powerful. Physical activity works in many ways, but reducing the body mass index is not the main factor. It's reducing the fat content. And as I mentioned, it has positive effects when it comes to the balance of hormones. Alcohol is a risk factor for all ages in case of breast cancer, more for postmenopausal, but also premenopausal women. Smoking, again, it's a consistent risk factor across pre- and postmenopausal women. And of course, there are environmental risks like radiation exposure, other occupation kind of exposures, which are less common as risk factors, but we need to be aware. So what are the recommendations? Again, the WCRF puts those recommendations together, and you won't be surprised by eating a healthy diet, being physically active, limit the exposure to fast food or processed foods, limit the consumption of meat and sugar is actually part of a healthy lifestyle. I would say that we need to be thinking beyond that. And when our patients come to our centers at ICON and we talk about treatment, we always talk about a holistic approach to treatment. So what can the patients do to help themselves not just tolerate the treatments that we give them, but very importantly, prepare them for a healthier lifestyle in the future and preventing further breast cancer. So you can see in the slides, there are recommended minutes of exercise a week, including strengthening and cardiovascular training, following a healthy diet, having adequate uninterrupted sleep, and avoiding alcohol and smoking. I think if we all do those things, and if we educate our patients, our colleagues, our friends, that will go a long way in improving our health as a nation. Couple of more slides. I want to also note about the challenge that we have in oncology around targeting the psychosocial component of this disease. It's not just about the physical, it's also, are we addressing the psychosocial? Are we addressing how patients feel and how do they cope with the treatment, but also how are they then inducted back into their normal life? I know Professor Nazanin is going to talk about that, but I wanted to frame the challenge that we are facing. And I'm going to finish by some initiatives that ICON Cancer Centre in London has taken. So we are looking at our strategy and our patient cohort, men's and women health services, not just as breast cancer or prostate cancer. So we have appointed multidisciplinary teams to cover those particular areas that have meaning to patients. So having gynecological support, menopause support, andrology support is really important. Access to one-stop clinics where patients can turn up even on a Saturday to actually, if they are worried or if they have found a lump in the breast, having a well-being consultant on site, partnering with other providers that have more extensive supportive oncology service, and supporting the charities that do the work and democratize supportive care across UK. Finally, we are very strong on patient advocacy, and we have piloted recently an exercise medicine program during chemotherapy, actually, for patients who are undergoing hematological chemotherapy, with excellent results when it comes to physical but also psychological outcomes. So I will finish there, and thank you for listening. And I will hand over to Dr. Reddy.
That was really fascinating, and the amount of work which has been done, truly a lot to learn from that. So I'm just going to speak on women's cancer and how we realized that it was so important in a country like ours. We are a 1.4 billion population, and almost 80% of our female population in India don't have access to high quality healthcare. And wherever they do, I don't think they realize that it needs to be specialized. And that is why we feel that women have to walk into a system which is designed and built for them. And that's probably why we built Apollo Athena. Apollo is the Greek god of medicine, and Athena is the warrior goddess, the Greek warrior goddess. And they happen to be brother and sister. So we thought that the name was effective, and it has caught on as a movement in the country. And I'm so happy and relieved that we're managing to do something in that space. Again, women, healthcare saw women, but never fully understood what they were, what had to be done for them. And to do that, many symptoms were missed. Sometimes women don't speak about issues which they have. They don't talk about or focus on it. And care was fragmented. They would go into an OPD, which was really an OPD for everybody and not specialized care. So it seemed like the shift was imperative, and that's why the whole movement towards women's health started with us. Our first initiative was Apollo Athena, which was dedicated to cancer care. And for us, that was the beginning. And having said that, now women are conscious. And what we're doing is that we've taken this whole Apollo Athena as a model, and we've said that we will plug it into our healthcare system. We're about 74 hospitals, and we have about 250 clinics. And all this is digitized, and Apollo 24/7, our digital arm, really talks to people online. So we're now working on an initiative where we will really take the Apollo Athena brand, and give it out to the public, give it out to the population, so that women know that there's some kind of specialist care which is designed around them. And in the cancer care area, it is early detection, it's precise treatment and holistic support, because I think women who undergo cancer, especially if it's breast or cervical cancer and sometimes GI or lung, they don't know what they have to do post-discharge. So I think the holistic support using digital, using technology has become really important for us. And we feel that we have to be intelligent about women's needs and wants. And that's why we said Apollo Athena would introduce gender intelligent healthcare, so that people know that they're going to get a little bit more than what is available, simply because that they deserve it. This is what it is. It's a small boutique hospital in Delhi, but it's a model which we're going to be scaling up throughout the country and maybe overseas once it's proven right for us. What it does is that it does have diagnostics, it has advanced imaging, minimally invasive surgery, including robotics. There is a focus on fertility, nutrition, and psychological support. So, every patient who comes in and out of the system has psychological support. Somebody sees them and is available to talk to them. And for us, it is privacy, it is dignity, great quality of life, and it is focused on outcomes. The future of cancer care, I'm just collaborating with people all over the globe. We know that there is so much happening in that space. What I'm not sure about yet is that are women getting the best because it's there and it's available? And are we helping women make the right choices? And that's why for us, the initiative becomes extremely important to raise the awareness. So for us, women's cancer is about providing gender intelligent care, providing precision care, and also being aware that the genomic makeup of women is not the same. So it's really not one size fits all, and research has shown that. And women tend to do this. They say everything is fine with me. I'm busy. Why check? Sometimes if it's serious, I really don't want to know. And they do push screening aside. So we're trying to see if we can find ways and means to work with the governments, to work with corporates who employ large number of women, and try and see if we can actually make it almost mandated. Sometimes a gentle mandate becomes extremely important for us. So the number of health checks and the prevention hasn't really been enough, is what we're seeing from data. But we also know that, 1 among 113 women really show up with early breast cancer. So I think the gap is in how do we get more people to, to come forward and screen themselves. To us, one of our most fulfilling jobs is the fact that every day, somewhere in India, especially in the smaller villages and remote locations, we screen people, and we're able to say that prevention is so much more than cure. We've actually screened more than 2 million women throughout the country over the past 5 years just for breast and cervical cancer. And the moment there is a diagnosis, then it kind of, the different ways and means for them to access healthcare to be able to afford it. And for that, we're trying to see if we can really improve outcomes for them. Because for us, it is just not a life saved in time, but if we can restore a life, I think that's really what the goal and agenda about this whole movement is. So we do have, we have buses which go into communities, into workplaces, campuses, talk to people and screen them. So that is kind of an on-the-ground screening. We have multiple awareness camps so that it's made visible. And this HPV vaccination, I think that has been for us, it's been game-changing. It took a few years of working with the government, working on policy to see that, how will they start implementing it in the country? Because for us, a lot of health it's a state subject. The national budget is there, which the whole country has a budget, and it is given off to different states in the country who kind of run their healthcare programs. So it's taken us a while to speak to the government, to speak to state governments, and say that the HPV vaccination is actually life-saving and game-changing, especially for young girls. And this is how, the prevention has moved from just awareness to early interventions. There are a few actions, as I said, and we're trying to scale it up. 6 lakh, which is 600,000. 600,000 screenings were done, and over a period of so many years, a few million lives were touched. This is this year's 2 years data. Sorry, so 2,400 people were identified and they were referred for further care. And wherever they could not afford it, funds were either from the state government or private sector. And then the women were screened, which was, again, 1.5 lakhs, that's again 150,000 just over the past few months for focused breast cancer programs. We've also done camps in remote locations like Meghalaya and all, which is, up in the northeast. Which is very hard to access, but using telemedicine and people physically be there, camps are conducted, and many community programs. So it's not just screening, but we're trying to build a system, training healthcare workers, frontline staff, and multi-channel awareness so that people participate. One of the cultures in India is that one day of the week in many of the villages or remote locations, people come together, and this happens in many of our villages. at that point, we find a way to go to these, and we set up a tent, we set up awareness programs, and talk to women, and women really come out and they say, can we talk about this? And then they're sent either to the government hospitals, which are supported by some of the work Apollo does, for interventions. And sometimes when it is, more complicated or difficult, then we absorb them in some of our centers. So I think these are all small interventions, and we are trying to see what we can do to scale up the work. This is again an example of what happens in Meghalaya and some of our locations. I think the future is what it is all about, where preventable cancer is truly prevented. These are some of our doctors who are participating in some of these events, where early detection then becomes the norm and not the exception, where vaccination protects before risk begins, and really speaking, truly committed to the fact that women should stay healthier for longer. Because India, the women are a very strong part of our culture. And, my father has 4 daughters, no sons. So I think we're all the more committed to the fact that, healthier women build stronger families, stronger economies, and a stronger nation. So this is what we have. And this is what we do, and we continue to do that. So thank you for the invitation, and I'm delighted to be here with all of you.
Amazing presentation. Thank you so much, Dr. Reddy. That was really enlightening. And seeing the work that you do with the different communities and the outcomes of how many patients actually have been screened as a result of your initiatives is really, really inspiring. So thank you. I will move swiftly to Professor Nazanin Darkhsan, and then we can keep questions at the end. The floor is yours, Nazanin.
I'd also like to thank the organisers for inviting me to present to you some of the work that we've been doing. And thank you, Penny and Preetha, for such an insightful, programme that you both have been pioneering. It's really, really encouraging to see that. So I'm going to pick up from where Dr. Preetha left and focus on mental health and psychological well-being in women with cancer. And, some of the things that I'm going to talk about, you may think they do extend to people with chronic illness as well. So we'll keep that in mind, but the focus will be cancer. So, in fact, I am flagging up the paper that Dr. Penny spoke about right at the end of her talk, where she talks about a model for holistic care and the urgent need to address the psychosocial needs of individuals with a lived experience of cancer. This paper was published in 2025. So as we have made, significant developments in medicine and medical care, what's been lagging behind is the global unmet psychological needs of cancer patients. So the prevalence of clinical levels of anxiety, depression, and PTSD, which stands for post-traumatic stress disorder, in high-income countries, around 30 to 50% of individuals with a lived experience of cancer have been estimated to have. And in low-income countries, this ranges between 20% to 70%. So these statistics show that we have a significant prevalence of mental health conditions that need addressing. A recent global mental health survey, which was published back in 2025, and I believe it was referred to actually in the paper that I mentioned earlier, looked at the mental health needs of individuals with a lived experience of cancer. 57% reported mental health stigma is common in cancer care, and 63% reported receiving no psychosocial support from their primary oncology team, and of those, 60% said that they would have wanted it. Now, a similar survey was distributed to healthcare providers of the individuals who had cancer. 50% perceived mental health stigma as high or very high, and 73% of them cited an insufficient number of mental health professionals for patients. So with rates looming high and with the rates of individuals who are able to provide mental health support being so low, we face a discrepancy that has produced that really big gap in healthcare. Now, I'm going to talk about very, very briefly a really big meta-analysis that was done a few years ago to look at the prognostic value of depression and anxiety on breast cancer recurrence and mortality. And some of the statistics I'm going to show are, can be triggering or they can be upsetting. So according to this paper, women with a lived experience of breast cancer are at a 42% increased risk of anxiety. And this in turn increases risk of recurrence and all-cause mortality by up to 13%. These figures are significant. And the more depressing picture for the contribution of depression was reported a 32% increased risk of depression, increasing risk of cancer recurrence and cancer-specific mortality by up to 30%. So in addition, this paper highlighted that the risk factors were lack of social support, younger age, and less follow-up from oncology team post-discharge of active treatment. So these are the figures. Let's see what the people with the lived experience say. I'm going to read this out for you. Overwhelmed and consumed by it all, finishing treatment is not the happy day it's portrayed to be in the media. It's just the beginning of years of ongoing worry and health issues caused by hormone treatments, anxiety, and ultimately depression. Fatigued and emotionally drained, life has lost its shine. I feel I've been given a chance to survive, but not to actually live. Breast cancer has left me feeling that everything is out to get me. I've shut down emotionally with except my kids, who I want to spend every minute with. Worst of all for me is I can't get my head around having any more treatment. So I'm now living with something that's potentially going to kill me, but my mental block won't let me do anything about it. And the last sentence speaks for itself. So the first quote was from someone with primary breast cancer. This one is someone with metastatic disease. There is good evidence now that links self-reported psychological distress with reduced predicted survival times in women with breast cancer diagnosis. So in this study that was published back in 2021, what you see is how self-reported distress is featured here in terms of projected survival probability. Those who rated their health as poor had a projected survival rate of 28 years. It went a bit further up for those who had fair self-reported health, and good self-reported health significantly greater. So we are seeing a pattern whereby mental health outcomes are affecting clinical outcomes. I'm going to touch on suicide here. And I think while these, pieces of information can be triggering and upsetting, but until we identify the issues and flag up the, ramifications that poor mental health is producing, in spite of medical advances and precision medicine, we are not going to be able to help people more effectively. So risk of suicide is 26% higher in individuals with cancer compared to that of the general population. And while we're talking about breast cancer, suicide risk is greater in women with breast cancer diagnosis compared with the general population, but also compared to other female-specific cancers. So the blues here are the breast cancer, and the other colours refer to uterine, cervix, and so forth. And this is across years from 2000 to 2017. This has not changed. So, part of the work that I do prior to being working in National Centre for Integrative Oncology, the NCIO, which tries to target exactly this, the lack of continued care in women's health. I set up the Centre for Building Resilience in Breast Cancer, and this centre was a research and practice centre for building resilience in women who had either a primary or metastatic diagnosis of breast cancer. And ladies you see here on the right or on your left are the students whom I've supervised and who've done considerable research at BRIC, identifying the key neurocognitive and social mechanisms of anxiety and depression in women with breast cancer. What we've been doing also is to design randomized control trials for better and more sustainable interventions that we have introduced new methods for intervening in terms of reducing anxiety and depression, specialist interventions, and in a way that we could be able to equip women with cost-effective and accessible tools to be able to empower themselves in survivorship and not be too reliant on their medical teams. This is just a very small sample of some of our publications from the research work we've done. Longitudinal randomized control trials on improving workability in women, which has a huge implication for their normalcy and well-being, and reducing longer-term anxiety and depression. So we've used a number of methods. Being a cognitive neuroscientist, many years ago, I trained as a cognitive neuroscientist specializing in anxiety and depression. I was very, very keen to see what we can do, what help we can get from the brain to empower resilience. Now, BRIC has a psychoeducational community support network, and we are currently about 2,500 women, and we have a collective voice whereby we raise awareness about the mental health needs of women with breast cancer diagnosis. And this page, Planning for Gold, has been accessed and read over 220,000 times. We implement projects and daily activities for building resilience. Now, all of this is captured under this amazing centre, National Centre for Integrative Oncology, which is a new charity led by Nina Fuller-Shavel, with a real focus on holistic care and continued care. And I head the Centre for Growth and Resilience in Trauma. And as a as a leader of this centre, we have introduced a CPD course for anyone with an interest in, oncology and cancer care, to be educated in psycho-oncology and trauma-competent care, so that oncologists, nurses, surgeons, any allied healthcare professional within oncology can feel a bit equipped to be able to support their patients better. And we have had amazing testimonials. As you can see, we cover a wide range of topics, and on-site training as well we do to equip our practitioners useful tools. And we've had quite good testimonials here. This is a bit of a projective thing for the course that I'm kind of publicising, because many people have said that it's been so useful for them. And as you can see, they kind of say, yes, anyone should do it. It's very useful, it's beneficial, and you'll also feel empowered to empower your patients. I'm going to stop there and thank you again for listening, and really I look forward to questions and discussion. Thank you.
Thank you so much, Nazanin. It's really fascinating, and it's absolutely true that mental health outcome actually influence clinical outcomes. And it's really astonishing to see how you mentioned 57% of patients feel a mental health stigma after diagnosis of cancer, which correlates very well with what the healthcare providers feel as well. So you describe really a real challenge there, but also gave us a bit of hope at the end that there's a lot of work done to improve that situation. And it's really remarkable for you and the team that have built that BRIC Centre, and you're doing the course. I think it's education is really important in that space, and it cannot be underestimated. I really like to we've got 15 minutes to open the floor for questions. I have seen something on the chat around there has been progress in some countries in reducing the stigma, in improving outcomes for women's health. But there are some countries that still lie behind. And as we mentioned, I think all the speakers mentioned that it's a socio-cultural situation that we are facing. It's not just access to treatments, I guess the system behavior within each country that also influences the opportunities that women have. So would anyone like to respond to that message on the chat around what can we do to improve the situation in those countries where women feel still vulnerable? Maybe somebody from the panel or... Yes.
In today's world, countries like Afghanistan and so many others are really being faced with challenges. And a lot of it is cultural, and to penetrate that cultural barrier, I think is very difficult. So we really have to teach and train women to empower themselves, because I don't think an external agency can go into Afghanistan and say, listen, the women have to be more empowered. I mean, we're seeing the repercussions of what happens. But I think we should be able to, maybe talk to them and reach out to them and say that from a healthcare perspective, you need to be able to take care of yourselves. Also, I think organizations like the WHO, since, IHF is in Geneva, and then a lot of aid goes into these kind of countries. And can we find ways and means to try and change policy? Because, we've kind of done it for some very secluded populations in remote locations within India to try and see, can the women actually be can those places be funded a bit better so that women's health? And we've made a very small dent, but I think these are things which have to be worked on over the years. So basically, I'm saying, can WHO be, requested to step in here? Can we communicate that, the other cultural aspects, I don't think we should even get into. But from a health perspective, can women in these locations just become more empowered? These were just my thoughts.
Thank you, Pritha. That's really very important points, and the role of WHO, as you mentioned, is critical here. But I get the feeling that also, countries like yours, where you achieved so much, contribution to the knowledge of how you did things and ways and tools to do it is also very important. IHF is an organization that brings countries together for that knowledge share. So, talks like this today, I think is an opportunity to open up further conversations. Okay. Any more questions from any of the participants? You can put on the chat.
It's okay. I actually have a question, if that's
Excellent.
okay. Thank you. I think it's mostly for Dr. Pritha, but I'm interested to hear about your community outreach that you do, where you get the tents, you do the education, the trying to get women early to take the steps that are needed to go for screening. I was wondering how that is taken by the men in communities, whether it's they play a supportive role, whether it's important to do outreach with them also to make sure that the women in their lives are getting those supports. So that, I'd be interested to hear that. And then after that, I have a question for Professor Nazanin, which is just a quick one that might be of interest to our audience around the BRIC and whether those training courses are accessible to international audiences or if it's only UK based. So maybe those two questions, please.
Thank you. I have to share this with you, but we come from a very small village in a state called Andhra Pradesh. My father is from there, and he's the first one who left the village to go out and do medicine and then moved abroad. So more as a community project, a corporate social responsibility, we started this program 10 years ago, which we call Total Health. And at that point, we realized that, the women were really having a rough time. And the level of alcoholism was very high because, the men, a lot of them were daily laborers. And the money they earned, they would go and drink, and then they would come back, and families went hungry, and the women were abused. There was also oral cancer because tobacco chewing is a big thing in some of our not so educated populations. So when we took this up, first we did screening for the women. We did cervical and breast cancer. Then for the men, we did diabetes, hypertension, and all that. So they felt that somebody was looking after them, so there was like an oversight. Then we started this center because we felt that the women are the ones who need to have a voice. And to have a voice, you have to be empowered. You have to earn money. You have to take money home, not be dependent on the male. So we made them do things which the hospital could buy, our hospital system. So they started making bags, scrubs, the edges of bed sheets, a whole bunch of things which we could buy from the hospital. So the women started taking money home. And when they became empowered and they were taking money home, they had a much stronger voice. And we found that, the level of alcoholism, better eating habits, better living habits, everything changed in the village. So we had data to actually prove what we're saying. And then Harvard came and made a study, and the Harvard Institute of Public Health kind of, showed this example globally. And now we've kind of made it like a protocol, and we're trying to implement it into different communities within the country. The government helps us, they send us, we get what we call the CSR budgets from corporates. So this model has worked. And I'm only trying to say is that, these are the things we have to do in countries which are underserved. We're talking to some of the African countries also, trying to see if they'd like to do this. So this was just an example I had from what you said.
Thank you. Really, really helpful, insightful. Nazanin, can I come to you for the second question?
Yeah, absolutely. So is it okay that before I answer the question, I'd like to make 2 points that extend Dr. Pritha's, explanation about the empowerment of women and women having a voice in more disadvantaged countries. What you say is very, very interesting, and I'd like to add to that and say that within more privileged countries like the UK, women are empowered to to highlight the vulnerabilities that they have faced as a consequence of cancer treatment, but they feel they're not validated. So their experiences are not validated, and they are not listened to, not taken seriously. It's all in their head. And so that's another issue we deal with here. And because they're not validated in terms of their experiences, many of the challenges with the side effects of ongoing treatments after active treatment go unnoticed. So that's kind of a challenge in itself. And you mentioned something about having the support being mandatory. That's really, really interesting that you take the support to the women. You go to the villages and you have the tent, and this kind of supports research findings that have shown when there has been psychosocial support, the uptake has been low, within oncology settings, but the complaints are still high, high levels. Unless the psychosocial support was made mandatory, you have taken the help to them rather than they coming to you. And I think this is a model maybe we can learn from as well in terms of engaging participants in the support that we can provide for them. And the question about the specialist interventions, Ilona, about the training and the long-term effects that we have seen. The course I'm teaching now at the NCIO covers all of those, and we're not just particular to people in the UK. We are very happy to have students from course participants from abroad. We're international, so it's a matter of signing up for the course and then sharing, training the practitioners so that they can then offer these to their patients. And so that's how I believe is best to disseminate accessibility to those training courses, because I need to train the person to then for them to go and be able to deliver the training.
Really helpful. And I really like going to the communities and actually mandating. And actually a participant has put something on the chat saying, but if we did that, would that change policy? And what has been the challenge in terms of actually having such health policy of mandating that care and that, looking after ourselves? I'll give you an example. We know the evidence around exercise, and even the NICE guidelines now say that we should be recommending it to cancer patients. But do we actually do that as clinicians? So there are, I think, challenges there by the whole system. What are your views? What are the challenges that you have seen in terms of influencing policy? Nazanin or Pritha?
Yeah, so it's very slow, and the idea is that the patient, the survivor will be able to take it up on their own and implement it on their own, whereas they have many other things that need addressing, and they can, I don't want to say use it as an excuse, but they need some kind of psycho education and perhaps need a bit of holding hand to start with, and then they can feel empowered to go and take on the exercise. Some are not so confident, some actually can feel fearful of doing the wrong thing at the right time. So taking support in informed kind of supportive interventions to participants may be a way for us to be able to engage and get some more commitment. Health policies, are very difficult to penetrate, and there's a lot of acceptance. But then when it comes to action, there's not much that kind of changes in terms of implementation. That's
Thank you,
been
Nan.
my experience.
And anything to add, Pritha, before we close?
I think in today's technology world, people are accessing information left, right, and center. And if we could have responsible communication for people, even in remote locations, a lot of them have smartphones. So I think we need to maybe work with technology providers and try and say from a global social responsibility, can we start talking to them about health and early detection and so on and so forth.
I agree.
Excellent.
I
Yeah.
agree.
We need a few powerful bodies to really make that. For
I
example,
agree.
in Davos, they should be talking to the Googles and the, Facebook and everyone, TikTok, and tell them that some amount of your communication has to be centered towards health.
That's so powerful, isn't it? All those platforms that we utilize day to day, I think that would be very powerful. Global social responsibility. I love that message.
Yeah.
Great call to action, Dr. Pritha, for the end of the webinar.
I think we are up to time, Ilona. So I would like to thank the speakers, everybody, yourself, IHF for organizing, ICON Group, and thank you to the participants who engaged with the session. That was, I think, really, really good discussion and a lot of positive outcomes coming out of it. So thank you, everyone.